This meeting is now being recorded.
Right, everybody, at 2 minutes past 1, I think we'll make a start, otherwise we'll never get finished in time. So I'm going to try and use the technology. I'm going to put everybody to mute. Like I say, if you want to ask a question halfway through or during the presentation, there's a Q&A button that hooks at the top of the screen, and you can type a question in and we'll come back to them at the end of the presentation. But I'm just going to see if I can... There we go. Right. If anybody, again, has problems hearing us, could you also just use the Q&A to make a point about technological things as well? We've got someone on standby to look out for those and to give you a hand too. Okay, so the first thing to say is thank you all very much for joining us today, this afternoon. My name is Diane. I am the Director of Strategy and System Redesign at Bedfordshire Clinical Commissioning Group, at least I am until next Thursday, when I'm leaving to come and join COBIC full time. This presentation is based on my experience in Bedfordshire, very much having turned the organisation into one whose strategy is to commission using outcomes. And we've really, as many of you may well know, have a contract, an outcomes-based contract live for musculoskeletal care, and another one for dermatology care, which has just started this month as well. We are midway through the procurement of mental health services based on outcomes, and we're also looking at different options around outcomes for children and the frail elderly. So the whole CCG strategy now is about how we commission on outcomes. Today I'm going to look at two aspects of outcomes-based commissioning, which is the two most important bits, one would say, which is how you get the money to sort itself out, and what are outcomes in the first place. So I kind of want to start really by basically re-emphasising that commissioners in CCGs really have two tools at their disposal. They have money, there's the multiple millions that come your way from Department of Health via NHS England, and you have outcomes for patients. You have the mandate from patients, whether that be directly through patient participation groups or indirectly through patient feedback via clinicians such as your GPs. In essence, those are the only two levers of a CCG you have. Everything else is done through goodwill and contracts. And it's how you make the most of contracts using these two levers that really an outcomes-based contract is all about. So what we're going to talk about in particular, we're going to look at money. We're going to look at the scope of your contract and how that defines, therefore, how much money you have to put into it. We're going to touch briefly on financial risk and transfer of that risk as well. And then we're going to look to see how you link the money and the outcomes together, which is a segue into looking at what outcomes actually are, how you can develop outcome measures, and then actually, once you've got a contract signed and started to be delivered, that's not the end of the story. Measuring and monitoring those outcomes is just as, if not more, important. So let's start with the money. And let's start again with the why we're doing this. So if you work for an individual organisation, individual provider organisation like a hospital or a community trust, then your whole emphasis, your whole aim is to be productive or as technically efficient as possible. And if you like, that's where organisations like the NHS Institute for Innovation have really worked very, very hard to focus on the productive ward, the productive hospital, and so on and so forth. And the concept is that as an organisation, you maximise your income and you make sure that income is used to its best possible effect, so you get maximum bang for buck within your organisation. You work hard through your cost improvement programs and so on and so forth to really make sure you can do no more with the money than you currently are in terms of the quality of care you provide. But what that really doesn't do is actually say, well, are you getting the right amount of money in the first place? You might be trying to maximise your income, but that may put you in a competitive position with some of the other providers in the system, and it might be maximising income, some might argue, to the detriment of other organisations who perhaps could have done more with it. So what an outcomes-based contract aims to do is maximise something we call allocative efficiency, which is the distribution of resources across a system, across a number of providers, so that across the system, all the providers working collaboratively together can really maximise the value they get for money across the system. So rather than competing against each other for the resources, you're collaboratively working together, aiming for the same thing in order to get best value for money. So just looking at that in a different way, if you're a hospital or if you're a community-based service or you're a general practice, you get a certain proportion of the cake at the minute. And one might argue that the bag of money sitting next to the hospital in the top corner probably isn't big enough, but bear with me. The concept here is each organisation has its own vision, its own objectives, its own goals, and it uses that bag of money it gets to really make them happen. Now what we do in an outcomes-based contract is take all of those bags of money and put them into one big bag, and then we say, there's all the money, and here are the outcomes that we want you collectively as a system to create, to produce and to maximise. And then in theory, at least, and what we're starting to see in practice, is that the providers will come together and say, well, if we have to make this money go as far as possible between us, then actually are we all doing the right bits of the pathway? Or are there other ways where we can really bring in more prevention and more early intervention and make this money go as far as possible to treat the maximum amount of people in the best possible way? And that then starts challenging the amount of resource that goes to different sorts of organisations. So the bag of money that goes to the acute sector usually falls. And it starts bringing in other providers that may traditionally not be part of the system. So in the bottom corner you'll see something that's supposed to resemble and represent the voluntary sector. Because actually, again, around community support, peer support, they may have a greater role to play than they do at the minute, and actually they may be the area that is worth investing most in. So that's the aim of the game really behind it, and of course then hopefully you can see that by understanding how much money you have and understanding what those shared goals, those shared aims are across the system, you can really then start to change the incentives for people to work together. So, as it says here, we need to be absolutely clear on the scope of what it is we're commissioning. We need to be clear on what age group we're looking at, what geographical area we're covering, what clinical condition we're covering, what care settings we're covering, and actually, as a CCG, how does what you're commissioning span interplay with the others, like primary health, primary care, public health and social care, where CCGs at the minute don't have responsibility for commissioning. So using Bedfordshire's musculoskeletal contract as an example, we said at the start, well, we're only going to commission for adults. But are you an adult at 16, 17, 18, or 19? And in effect, we end up defining adulthood, in our case, as 19 and above. Now, that does lead you into the first question then, which is how do you manage the transition between children and young people services and adult services? But already you start to draw a black line around what your scope is, what you're defining in this contract. In our geography, we said we're covering all of Bedfordshire CCG. We have to be quite careful, though, again, to say we're covering Bedfordshire CCG, because Bedfordshire, in terms of the local authority and general public's view, it also includes Luton, which is its own CCG. So again, we have to be very specific about covering the people who are registered with a Bedfordshire CCG general practitioner. Clinical condition, we used ICD-10 classification and said we are covering all of Chapter 13 in ICD-10, which is the musculoskeletal chapter, and that gave us a very neat definition of what we covered. But we also had to be explicit that we weren't covering trauma services, just planned care. Then again, you get to the question of, well, what about fracture clinic? Because it's planned, but it's planned as a result of a trauma. And I'll come back to that a bit later, and if I don't, please remind me. Care setting, well, we are a CCG, and we have not co-commissioned this with NHS England, so our sector covers community care, hospital care, and voluntary and charity sector care as well. But at the minute, we did not introduce the levers to commission primary care as musculoskeletal, at least not in terms of core general practice. Again, we'll come back to some of the enhanced service options that might be available. And in our case, in terms of the interdependencies and the overlaps with other commissioned services, we didn't include fault awareness schemes, which are commissioned and led by public health in our area. As I say, we didn't include just primary care, but we have looked at encouraging more joint injections and other enhanced GP services to be undertaken. One of the reasons for looking at musculoskeletal as a sort of first outcomes-based commissioning contract is that social care in reality don't have that great a part to play in it, and so it was relatively easy to not define social care as part of the scope. But of course, in other areas like frail elderly or children, social care is very much something you would want to consider. And specialist commissioning, well, we find that a bit of a movable feast, if we're honest. So although at the outset our specification does not include anything that's covered by specialist commissioning, as many of you will be all too painfully aware, the IR rules seem to change on a daily, if not weekly, basis. And so actually we find that sometimes our scope is fluctuating, but we're doing that in conjunction with the prime contractor, not having problems with them. So let's look then at what we've called the programme budget. And the first thing I guess I better make sure is, what is the programme budget? And for us, it's very simply the money that pays for all the care for a specified disease or population group. Again, as many of you will know, the Department of Health have for many years run a series of programme budgeting calculations so that you can, as a CCG or as a PCT in the past, benchmark yourself against the national, local and peer groups in terms of how much you spend. And that's a good starter for 10, that Department of Health benchmarking set. But I'll be honest, when it came to doing something of the level of detail of this contract, even though there was a musculoskeletal programme budget in that Department of Health data set, we actually kind of had to start from scratch again with a blank sheet of paper. And we did that basically in this way. We started with what we thought was the easiest bit by looking at our PBR spend. And yes, that was easy to begin with, but we had to build in a number of assumptions from the outset. So for example, we need to look at marginal rate adjustments on existing tariffs, such as the 30% emergency admission rate or any implications in effect that had on elective care. We had to look at some of the local tariff arrangements we had in place. We also built into it what our current knowledge and our best guesses were of the future tariffs over the 5 years of the contract. And we also had to build in the sequence payments that we either would or would have put into these contracts had we continued to commission in the normal way. And that really is for inpatient care relatively straightforward. But actually, again, as many of you will know, outpatients, the data set around outpatients is notoriously unreliable and very vague. So we had to make sure we were very clear on our assumptions around which outpatient clinics fell under the musculoskeletal planned care banner. And again, there were a list of assumptions that our financial analysts made and tested out, asking advice from other colleagues and checking it out as well with other members of the department as to whether those were appropriate and rational assumptions to make. Again, there was the issue of when is an elective procedure and not an emergency one. So I mentioned fracture clinic. In the end, we decided fracture clinic was in scope, partially because when we got to discussing how it would work pragmatically, fracture clinic is treated by the clinicians in pretty much the same way as any other outpatient department. So we decided that this was, albeit a slight overlap with emergency care, with non-elective care, but actually for us it worked to keep it in scope. So to some extent, the scope is one of those things where you can have a starter for 10 and it's really good to scope it out as far as you can. But it is something where as long as you're clear and transparent, and actually as long as you build in some flexibility into the specification during procurement that allows you a bit of wiggle room during the due diligence you need after the procurement's finished, actually you can flex the scope a little bit. One of the things we built into the specification around the procurement was the possibility in future years, should all go well, of building in more trauma, more emergency MSK care into the contract. Block contracts are even more difficult because the service line data, if you have it available, is often a best guess rather than an accurate detail of what finance you have available. So again, it's about being clear and pragmatic on assumptions. In our case in musculoskeletal, the biggest one for us was around podiatry, because our podiatry team didn't really consider one patient to be a musculoskeletal and the next patient to be anything different. But in reality, you had musculoskeletal care, you had diabetic care, you had other types of care as well. So one of the things we've done is just be open and honest and transparent and say, actually, we're going to have to test some of this in the first year and work on understanding our assumptions, whether our assumptions are valid, and if necessary, change them and adapt the programme budget accordingly in the years 2, 3, 4 and 5. We've also included enhanced services. Again, the ability to include enhanced services without the wrath of general practice descending upon you is one of the reasons where in other presentations I talk very much about the importance of good and repeated engagement with all clinicians and all providers, not least your own members of CCG. Because unless GPs really understand why you want to take away their direct access physio and put it into something that looks on the surface of it more complicated, unless they can understand the bigger picture, you're likely to be making a bit of a rod for your own back in this one. And then other parts of the map that you need to include, of course, are the independent providers, any relevant AGP contracts that you have in there, are they in scope or out of scope? And don't forget voluntary sector contracts or grants that you may give out as well. They may be small, and again, they may also create noise in the system if again, you don't have those open and upfront conversations with voluntary and third sector bodies, so they understand that actually they may stand to win from this and this is not a lose. And again, it's about investing the time up front to explain to them what is happening, why you're doing this, and what the opportunities are for them as a sector in all of this too. So once you've got that programme budget put together, once you've managed to compile all those different pots of money into one single programme budget, the next thing that providers will want to know, and the next thing you'll want to know, is actually what the level of risk is in that budget. In other words, how often could a big cost case risk blowing your budget? And for our musculoskeletal condition, the thing we thought about was, a patient who's had a hip replacement that needs it redone, it's gotten infected, the patient is already, got heart disease and diabetes with COPD and is at high anaesthetic risk. They end up having a long stay in intensive care and long, prolonged hospital admission and long recuperation after that. What we did was invest in some actuarial modelling to understand per member per month detail what the cost of admissions were. And you can see a snapshot of one of the graphs we produced, which shows you there are two peaks in musculoskeletal planned care. There's one which is the numbers of relatively low-cost procedures, which tend to be endoscopies and day case procedures, and then a smaller peak, which tend to be your standard hip joint replacements, your knees, your hips and your knees. And actually, in our case, in musculoskeletal, the actuarial modelling showed there weren't any really big cost cases, and the insurance risk for musculoskeletal in our situation was relatively low. That's one of the things that as a potential prime contractor or as a potential alliance group you want to know, and it's reassuring to people to give people that information up front. So again, one of my recommendations is to think very carefully about investing in that actuarial modelling. So the next thing then is about, okay, you've got your programme budget, you've done some due diligence yourself, now you get into conversations about financial risk. And what do I mean by that? Well, today, commissioners like CCGs, as you know, are paid per capita. We get paid that budget depending on the number of people registered with the GPs in the member practices. But we don't pay our providers to tend in that sense in the same way. Things like PBR mean we pay per attendance and per admission, which means commissioners hold all the financial risk, as we all too well know, part of the problem. So what this is in an outcomes-based contract is actually trying to align that level of risk into something that makes more, that transfers through. So that commissioners and providers are both paid per the number of people they either serve or care for, which means there is some financial risk transfer to providers. They share the same problem of trying to live within, in effect, a fixed budget, where a budget isn't going to grow unless the number of people within your population grows. And that causes a problem potentially for the way I've described an outcomes-based contract to date, because as we know, primary care and general practice is where the referrals into the system are going to come, and yet at the minute, in my description of this, they tend to be out of scope. Now in the future, of course, co-commissioning provides us with an opportunity to bring general practice in scope for some things. But there are ways and means of basically, although general practice might be out of scope, of bringing them in. So there's some carrots. Certainly when we talk to GPs around our musculoskeletal work, they actually want to be upskilled. And they're quite relieved whenever they understand that an integrated musculoskeletal system, for example, isn't going to detract from GPs doing things like joint injections and doing more care in their practices. In fact, they want to do more, and of course that's just what a prime contractor and a capitated budget would want as well. Actually, the more care that can happen in primary care, the easier it is potentially to live within your budget, but also the better it is in terms of meeting those outcomes, those shared goals that general practice, the CCG, and the integrated system will have together. there is a stick. It's perhaps not the biggest or thickest or longest, but again, assuming that the relationship between the lead provider and the CCG is positive and open and trusting, which after having gone through the due diligence around the finances, it hopefully is, then the two organisations can work together to look at variation between practices in referral rates, in relative spend, in use of diagnostics. And the CCG, of course, still has a mandate to improve quality of care in primary care and can use the information coming from the lead providers to help improve the quality of care happening in its member practices. So whilst I say it's not the strongest stick, it is at least something. Now, a lot of this will depend on the size of the CCG's appetite for risk, because in effect you are handing over a lot of financial risk, usually tens to, in our case, hundreds of millions of pounds of money, to an organisation that you have a contract with but really no other lever. And as I've said, that then puts a lot of emphasis on having really strong and positive relationships between the CCG and the lead provider for that contract. So you've got your programme budget, you've done your actuarial modelling and understand the level of risk that's carried within that budget. You have looked at the relationship in terms of risk transfer. You've thought about the working with general practice and how to bring general practice in scope, theoretically, even if not in scope contractually. Now, how do you really make money and outcomes tie up together? There are, in fact, three ways. I just need to warn people, we're actually in the middle of a thunderstorm in London, so if it all goes horribly jittery, it's not me, it's the thunder and lightning. But anyway, so there are three ways of linking money and outcome. The first is perhaps the first thing you would think of, and if you like, in the title of COBIC, it's the incentivisation of outcomes. But these are outcome measures that really are game-changing. They're the ones that will really make a significant difference to the way people are able to live their lives, to their outcomes. And that will usually mean a significant difference in the quality of care provided and the way that different parts of the system interact with each other. You really only want to be rewarding something that is not the norm, that is well above the norm, and improves the quality of care significantly. The second thing you can do, of course, is set a set of core outcomes that are kind of assumed to be in the baseline. And many of the NHS constitution measures, for example, like 18-week waits and healthcare-acquired infections, this is where you would put those sorts of indicators in. Because here, the assumption is that in the core pot of the programme budget that the prime contractor or the system is going to get, these come as standards. This is what you expect. And you would potentially penalise the system if they don't deliver them. The third way of introducing outcomes then is a more qualitative description of what it is you expect the system to look like, to feel like, to use, either as a patient or as a GP. So they're not directly incentivised or penalised, but the ability of either the systems of being able to deliver them will impact on the two above. It will impact on the core outcomes and an ability to deliver the game-changing outcomes. So in pictorial form, if this orange box is the total size of your programme budget at the start, then you may have the additional incentives. You may have the additional incentive payments added on top of it, but that dark orange box is the core amount of money that the provided system would be expected to deliver that second category of outcomes in. It may be that they don't deliver those core outcomes, in which case you can penalise them. Conversely, they may actually be able to deliver some of the game-changing outcomes, and they may still attract some of the incentive payments, but not if they miss things like their 18-week standards, for example. And if they aren't able to deliver the qualitative feel of the system, the way that you want people to experience going through it, they may both miss some of those core outcome measures, and they may also not be able to hit all the incentive game-changing outcomes either. So there's different ways that providers can have, increase, and actually potentially lose a little bit of their programme budget. Now, how do you decide the relative proportions of what goes into that core budget, what goes into the incentive-based payments? Well, this is, to be honest, where perfectionism sometimes has to be trumped by pragmatism, and it certainly was in our case in musculoskeletal. So I had a great ambition that we would start off with 95% going into that core budget and 5% in the first year going into the incentive-based payments, and increasing that year on year so that by the end of year 5 you would have more of a 75-25 split. In reality, This is a very, very new concept, and the market is very, very nervous about trying to actually take this on board. And my CCG was just a bit sort of, hang on a minute, you want to do what? So to some extent, the relative proportions depend on your CCG's appetite for risk and how willing they are to put more in the core budget or more in the incentive payments. There's also the sense of, well, actually how important is our outcomes and the delivery of better quality care in the CCG. They may really want to feel that incentive payment is where they want to invest a lot of money. It's also something to be pragmatic about the size of every CCG's financial challenge. Actually, how much do you want as the ability to have as savings in terms of top line from the programme budget, and how much are you willing to negotiate in terms of the prime contractor. And although my experience was such that I had to be pragmatic in the end and settle for something that was not quite as heavily incentivised as I might have liked, actually as this becomes more of a common and accepted way of doing business, it will become easier to negotiate greater proportions of the programme budget around the outcome measures. Finally, it comes back to that appetite for risk and the incorporation of demand management. The stronger the prime contractor feels its levers are to work with general practice and to work with the CCG with general practice, the better able they will feel to carry the financial risk. And again, I can't emphasise it enough, that comes down to the strength of the relationships and trust that the two parties have between each other. So again, in pictorial version, for any business case looking at developing an outcomes-based contract, you'll want to know what your spend has been in this programme budget area over the previous years. And I'd be surprised if it doesn't look like this, with year-on-year spend increasing. Now, what you'll almost certainly want to do then is take a little bit of that top slice off for your CCG savings, because again, you will assume efficiencies within the system. And you'll look to see how much you feel should be in the core budget, how much can go into incentive payments. And then over the following 5, 7, 10 years of the contract, then it's up to you to negotiate, to plan and then negotiate in changes to that as you see fit. You may be able to tell that the overall budget goes up slightly because the population is going to grow and it's going to age as well. And so that budget will go up slightly, but in no way to the same extent as it's been going up year on year before the contract's put in place. Also to consider, don't forget, set-up costs and management costs, and to some extent exit costs from a contract as well. But these will all come out of the programme budget and not the management cost setting. And again, providers will be factoring this in as they cost up big. So just be aware of all of that too. So I want to move on now to look at the outcomes that go into a contract as well. So the first thing to say is, well, what do we mean by an outcome? And to some extent, those of you who either have a public health background or know a bit of public health will hopefully recognise at least the first expression, the first set of phrases on this page. So Donna Bedian was someone who said, you know what, we need to be really clear about what we mean by structure, by process, and by outcomes. And working back from the end point, is patients' outcomes are dependent on the processes we put in place to deliver those outcomes. And those processes should therefore drive the structures we need to deliver the processes, to deliver the outcomes. But it should be that way round. Outcome drives process, drives structure, and not, as we tend to do in the NHS, have structures that drive programmes that then drive outcomes. And in particular, I like this definition of what an outcome is that's been given to us by the International Consortium of Health Outcome Measurement. They say that outcomes are the results people care about most when seeking treatment, including the functional improvement, and most importantly to me, their ability to live normal, productive lives, the lives that they want to lead. To some intents and purposes, some of the things we measure, like readmission rates to hospital, are important, but we have to be clear we're measuring them because they're a proxy for something that matters to people, and not necessarily because it's something that matters to the structures or the processes. So how do you develop outcomes? Well, it's actually becoming a little bit easier to find outcomes that others have developed that you can potentially apply to contracts such as these. They're not widely available just yet. Certainly, when I was doing the musculoskeletal work, we had to dig hard to find them. But increasingly, the whole NHS seems to be moving towards this way of thinking. So we have the NHS Outcomes Framework, Adult Social Care Outcomes Framework, and the Public Health Outcomes Framework, which give us high-level population-wide outcome metrics. And those may in particular be useful for people with long-term conditions and the frail elderly. there are increasingly pathway and disease-specific outcome categories, outcome measures as well. So I mentioned ICHOM. They're an international organisation whose sole purpose is to create groups of outcome measures that are based around diseases and pathways such as cataracts, coronary heart disease, low back pain, Parkinson's, and so on and so forth. And their essence is that they can create a core of outcome measures for each of those pathways or diseases, and have each system organising, each system in the country or in the world using them. Then actually we get to a point where we can really compare properly healthcare systems in this country, in Sweden, in the US, in Germany, in Australia, and across the world, and find out what are the structures and processes that really allow better outcomes to be driven, to be happening. So I would encourage people to look at their website. And I'd always also encourage people to look at research pages as well. Outcome measures have been developed, particularly for pharmaceutical trials, but they tend to be buried deep in the literature around those, and not necessarily an easy reach yet of people like us who might want to use them for contracting purposes. And finally, I'd encourage people to look at relevant patient groups as well. So for our MSK contract, I looked at the National Rheumatoid Arthritis Society, and they, with partners, have created a set of outcomes around rheumatoid arthritis, as the name implies. And Macmillan have done a lot of work in the cancer area, looking at eye segments, things that are important to people who have or have had cancer. So increasingly, there are areas we can look for more off-the-shelf outcome indicators. There are also things as well like national surveys, which help us understand the care that people experience for long-term conditions. There's also other things that the ONS run, like national bereavement surveys. And we know that there's national audits run by the Royal Colleges, but also there's local clinical audits that will be done by our local providers, but actually probably never make it beyond the front door of the institution, and may actually be very useful to take and apply at a system level. In the end, though, we may actually have to do work of our own, and that may involve actually developing our own indicators that are specific to the area and the condition that we want to look at. And so that means running workshops with patients, with clinicians, and bringing people along with you. And actually, I would encourage you to do that, even if you do have something you can lift off the shelf, so to speak. Because even with readily available measures, they need to be owned by the people who are going to be either trying to apply them, or by the people whose feedback you're going to want to get them. And so the two questions I find very useful to try and phrase in this way are to ask local people, not what's the matter, but rather what matters to you. What's important to you in terms of what you want to get out of healthcare? And good health is often one answer they start with, but actually good health is the enabler that allows them to do other things. It allows them to play sport, to collect their children from school, to go shopping. And so actually what you want to understand is really what matters to people, and to work out and turn those into outcome measures. And similarly, it's been very interesting asking local clinicians how they know they provide good quality care. And also it involves asking them time and time again, well, why is that important and why is that important, before you really get to the nub of what it is that really matters. As I mentioned earlier, process indicators can be used, but you've got to be sure you're using them for the right reasons, that they're good proxies for outcomes that you really want to try and achieve ultimately. So just to summarise that then, you may find that there are indicators that are available. They may have been used in surveys in the past and are very good, validated indicators, but they're not currently collected and they're certainly not analysed and reported in any systematic way. So that's a good starting point then for at least saying, how do we create a system of collection and analysis locally? You may find they're available and collected, but not necessarily analysed and reported at a local level. So some of the national, so for example, the national bereavement surveys, perhaps not as widely used or applied as it might be. And then there are other indicators like the NHS outcomes frameworks, where we have those already at CCG level and applicable. But do bear in mind that it may be the case that you need to develop some specific local ones. And in that instance, there's plenty of opportunity for collaboration with CCGs and with academic institutions around the country. So again, going back to our musculoskeletal example, we've been able to liaise and work in conjunction with the University of Oxford about the development of an MPROM, a musculoskeletal patient-reported outcome measure that they've been piloting. So again, look out for opportunities for collaboration and joint thinking and learning. So on to measuring and monitoring them. And believe you and me, if you think the difficult bit was getting to the point of developing the contract and the specification and then signing it, you ain't over yet. This is where the fun really begins. The first thing to say is that as you go out and speak to your providers about the outcomes you want to measure, that you want to collect and that you want to improve, you don't necessarily have to specify how you want those outcomes measured. Because just like providers know potentially the best way of redesigning services to address and meet and improve those outcomes, they'll also have their own ideas about how they can collect the outcomes in a sensible and logical and cost-effective manner. It is, of course, that said, worth checking it out, but don't feel you have to build the whole engine yourself. A lot of this is about using the information and the intelligence that's out there in the provider sector. And of course, this is a new way of doing things. There are new rules in terms of these contracts. There's new payment mechanisms. So you've got to look out for the unintended consequences. You've got to look out for where spend all of a sudden seems to increase in other areas you haven't expected. And that may be, of course, because you've not quite got the scope right. There may be things that should be in scope but haven't been thought of when you've been designing it. And there may be some things where you've got it wrong. So one of the things in our musculoskeletal system we've looked at is diagnostics. Diagnostics has, of course, been unbundled from the inpatient tariff, but you don't have a label flagging up which is a musculoskeletal diagnostic use and which isn't. So we've run with the CCG holding the budget in year one for diagnostics, but undertaking an audit to understand the use of MSK-related diagnostics, with the ambition of adding that into the programme budget in years 2 and forward. So to look out and be aware of some of those areas where you may need to revisit the scope. And also look out, as I mentioned, for legitimate opportunities to increase scope, like, for example, our potential ability to add in more trauma-based services into our musculoskeletal contract in future years. We have said it was an option potentially during the ITT process, and it's something we're just bearing in mind as we get our new integrated musculoskeletal system established and start to see the impact of it in reality on patient outcomes and how that changes the processes and structures behind. Now, just as this contract is a new way of doing things, it also is going to require a new way of monitoring the care that people receive. It's going to be much more heavily based on feedback from users and GPs, and you'll want to see changes to population health indicators as well. So it's not going to be as simple as just the usual collection of 3 or 4 people who meet monthly in a room from a CCG contract department and the senior management team from a hospital or another provider. Actually, you're going to want to start playing in there patient voices and GP voices as well. And in some respects, it's up to you as to how you do that. You may actually have physically the GPs and users in the room, or you may want to conduct your own independent surveys or have that built into the contract monitoring system and have that qualitative and quantitative information fed in as well. You'll also need to be quite clear up front about when any incentive payments and when any penalties are either released or incurred. You need to be clear about the thresholds and targets to reach at each indicator milestone and when those milestones occur, monthly, quarterly or annually, and also agree the what if. So one that we experienced was, well, what if we miss the target for an incentive payment in quarter 1 but overachieve and hit quarter 2's target with room to spare, which means we automatically have hit quarter 1's as well. So we negotiated a type of catch-up payment in that instance, but we said you've only got a limited window for being able to achieve that catch-up payment. So there's some sort of what-ifs that you may well need to play through with any preferred provider or prime contractor. And finally, the one thing I guess I hope I'm getting across to you is that the development of an outcomes-based contract and the running of that contract is not something that is just part of a small part of the CCG. But actually this is something that needs to become the whole CCG's problem and the whole CCG's way of business. Right through from the finance team understanding how to put the programme budget together, the quality team understanding what local priorities there might be in that disease area, the local GPs really getting behind what it's going to mean for them and their patients, and being able to describe what the system needs to feel like for both those groups of people in order to feed that into the qualitative version of the outcome measures. It needs to be part of the contract team's work to understand how the contract is put together and what the implications are for them, taking it forward through into monitoring and management after the contract signed. And commissioning and system redesign and public health all have a huge part to play in developing the specification in the outset. So this is not just something that a small group of people within a CCG need to own. This is something the entire CCG needs to take on board and actually need to put their weight behind them. And they'll need to, because at the end of the day, There's likely to be noise in the system. There are likely to be comments and questions and queries from, dare I say it, not least the acute sector, who see their budgets changing and who perhaps haven't quite understood or realised the level of collaboration that we're now looking for in these new style contracts. But there are side effects of big success. So all of a sudden, this mantra of we should be engaging patients more in their own health becomes, well, we need to engage patients more in their own health because we need to find out how their outcomes are being met if at all in the first place. We need to engage people more in how you redesign healthcare services, and that's a side effect of this. We need providers to collaborate as well as or instead of competing, and we need to improve value for money, and that's the whole essence behind these contracts. So my parting words before we open up to questions. If you've always done what you always do, you'll always get what you've always got. This is a brave new way of doing things. It is going to involve everybody in the CCG, so you've got to know your CCG's appetite for risk and for innovation, and make it clear that this is not something necessarily to be entered into thinking it's going to be a panacea. It's not. It's going to take time and it's going to take lots of engagement, but you can do it. It can be done. And to make it successful, invest the time and the effort in getting the skills and therefore the programme budget right. Invest in the financial analysis that you need to do. We invest, at the end of the day, when we appointed a preferred provider for our musculoskeletal contract, we went right back to basics on our due diligence over the finance. And at the end of the process, sitting alongside and recreating the programme budget with the prime contractor, we came in within £100,000, within a couple of £100,000 of the budget we said at ITT stage was going to be that available, because we'd invested the time up front in the financial analysis. Really importantly then, in terms of outcomes, resist the temptation to over-specify the contract, because you then run the risk of doing exactly what perhaps the problem's been in old-style commissioning, which is to assume that the commissioner knows more about how to deliver care than the providers actually delivering that care. So make sure to focus on high-level outcomes that matter to local people. And as I said before, actually don't feel the need to have necessarily found all the outcome measures by the time of tendering, and certainly not necessarily all the ways of measuring those outcomes by the time you tender. There is a degree of negotiation and flexibility that can be built into the process. And depending on how you contract, whether you use a competitive dialogue process or some other method, you may find that providers themselves have some good ideas for the outcomes they feel in their experience on the front line matter also to patients and staff. So just in case you think this is actually really difficult and this can't really be happening, actually this is now part of a growing movement of outcomes-based commissioning across the country. We're not alone in Bedfordshire for having actually awarded contracts, and we're certainly not alone in terms of developing other contracts as well. There are plenty of places, both in terms of across the country and across a number of other disease and population groups where this is all happening. And finally, if you want to know more, well, part of the way we run COBIC is by having a COBIC club where we have these monthly seminars where members can learn more. And I'm very happy also to run telephone conversations with any of you who might want to delve into some of these aspects in a little more detail. We can also come out and visit you in your area. And if you want to ask more questions or find out more about either outcomes-based commissioning or what we do at COBIC, then contact Carol-Anne and she'll tell you more. So I can see we've got a number of questions coming in. I'm going to let Carol-Anne take over the logistics now.
Right, I've just unmuted everybody just to bring everybody in. Just see what questions we have.
Okay, first question is about actuarial modelling, how we source that. So we had a procurement expert alongside us during the whole Bedfordshire MSK work, and we used our CSQ and our procurement advisors to advise us and to find a source of actuaries who could help us. They were a company who were very used to dealing with the private health insurance market, and so did it for them all the time. They've been very excited about the opportunities of doing this more for NHS-based contracts. So the company we used was Milliman, although I think other companies, of course, other suppliers are available.
Right, so we've got a few more questions here.
Highly lucrative. So the next question is,
Yep.
how have you been able to assess the financial gain over the duration of the contract, taking into account population growth? So we basically, our finance team already have assumptions about the proportion of growth they expect, both in terms of demographic growth and non-demographic growth. They're based on the sort of, assumptions that come out of the NHS finance circles. But we also had a fairly good indication from our public health colleagues as well. So we negotiated, I think it was about something in the order of 1.5% per year. Next question is about assumptions we made to set up and management costs within the financial model. We pushed hard on this actually about making set up and management costs explicit within the programme budget, and we've worked very hard to minimise the impact of management costs. However, when the prime contractor described to us what they meant by management costs, it was pretty clear that they were talking about the sorts of things like care coordinators, patient choice advisors, people who would actually make a real difference to how the system was coordinated, the system was run. So we, once we understood what was being encompassed in those management costs, we negotiated it as a percentage of the overall programme budget as a maximum capped percentage. The next question then is about, in terms of price we went out to market with, was it our bottom line price, or did we model an additional figure and create a buffer for ourselves? We had basically looked at, if you remember the graph about the year-on-year increase in terms of how much spend we had in our musculoskeletal budget. In terms of Bedfordshire, we're a fairly efficient health economy already, and one of the points where pragmatism had to trump perfectionism in my world was that we actually ended up having to take more of our savings based on what would happen if we didn't change kind of approach. So it was, we based our business case to some extent on, if we don't do this, our costs are going to continue to rise. So the figure we went out to market with was pretty much, with a little bit of leeway, the amount of money we currently spend on musculoskeletal care at that point in time. Let me see, next one. Is it all under the standard NHS contract? Yes, it is. We have one standard contract with the prime contractor, and that's using the standard 1415 NHS contract. And yes, we did go through a procurement. We went through a standard part of the ITT process. Contract went live on the first week of April. So we're just in the process of evaluating the early impact at the moment. I only really have anecdotal information to give you, but I do know that our local district general, who had waiting times of 18 weeks and then some for elective orthopaedics, has seen the number of people choosing to go there fall whenever if choice and wait in terms of making their choice, if waiting time is important to them, and they are given information about waiting times in other providers, they are choosing to go to providers where the waiting time is not as long, which, as I say, have had an impact on the number of people who are choosing to go where they would have gone before, which has been to our local DGH. We're also seeing some influence in terms of more self-management as well. Patients not necessarily touching healthcare services at all in terms of the musculoskeletal system, because they're getting more advice about how to care for themselves. How long has it taken to put this new contract in place? So blimey. We started this in November 2011 and went live in April 2014, but to be honest, actually a lot of that was because we were doing this during transition between PCT, CCG, SHA and NHS England. The bit that took the longest time was just trying to work out how we got hold of procurement advice whenever CSUs didn't really exist. So I suspect there's a lot you can condense or concertina in terms of our timescale. That said, we took that opportunity to do more engagement with our GPs, to get more feedback and to refine the specification, so it wasn't wasted time. In terms of how providers work together, we've seen our independent physios, with whom we had quite a lot of very small contracts, actually start to play a bigger part in terms of the community-based service, and they've had a greater role to play. And we're starting to see the consultants who are based in the hospital actually start to get really excited about some of the things they can do in terms of community-based care and the opportunities they have outside of operating theatres. For them, this is a good way of making sure that the people who need surgery are the ones they see, and not just whomever the GP decides needs to be referred. The contract is with one prime contractor who then subcontracts with a number of other providers, so it's done in that sort of very much prime contractor route. And why did we choose MSK? Really good question. Partially because when we looked at others nascent CCG, planned care was our biggest area of spend, and we needed to do something in terms of our quick challenge. And within planned care, musculoskeletal was the biggest volume and biggest cost area. So, and we had some outlying areas like our use of less effective procedures was higher than we would expected, and we seem to have a very heavily hospital-based model of care with inequity across our patch in terms of what types of care was used. So it was a priority for us on all those sorts of levels. Outcomes achieved to date, as I say, it's been around that change in patient flows. And how did we convince the CCG to do it? You know, that's really interesting. I went in to the first executive meeting of the CCG in late 2011 and said, I had this idea, I think we should commission differently, and I think we should commission around outcomes. And I really expected a strong pushback to say, you want a what? No, we don't do it like that. No, we do PBR and contracts. But actually, perhaps it was because it was the very first CCG executive, perhaps it was because that's the way that clinicians and GPs think. But actually, the whole item on the CCG executive agenda took 10 seconds because they went, yep, that's of course the logical way to commission. Get on and do it. And so we did. We will send out a copy of the core webinar. It's not just the slides, but you get to hear my dulcet tones as well. Send it to all the email addresses of the people who registered for this. And the lead provider, sorry, just working down this list of questions, the lead provider is Circle, who basically are working in collaboration with one of our local GP provider organisations, and also in conjunction then with our local, under subcontract then with our a network of local providers that already have existed. The prime contractor therefore isn't a joint venture, it is just Circle and whatever subsidiary of Circle Limited they've set up to run it, but it has been very much them. In many ways actually, of course, they aren't necessarily a provider of services within Bedfordshire, albeit Hinchinbrook is on our doorstep, it's not a major player in our health market. But Circle are working hand in glove with, as I say, this GP provider company that is very much running the show. And that's been very important too, and that's provided a lot of the local leadership, which is, again, helps build the credibility with our local GPs and with local clinicians. There we go. So that's all, I think, that's all the questions we've had typed in whilst I've been talking. Hello, we had a couple more answers. Anything else I can help anybody else with?
Yes, like to see your slides.
Have any of our main existing providers refused to be part of the model through? That's a really good question. The answer is yes. In fact, a number of things have happened. We've had some existing providers who said, yep, that's fine, we'll sign on the dotted line and get going. And not surprisingly, we actually really had quite a strong private sector market. And they all signed on the dotted line pretty quickly. And not surprisingly, did Hinchinbrook, given the fact that Circle are the prime contractor. Many of our big NHS trusts needed a little bit more working through and walking through what the implications were for them. And we've been bringing them on in a phased approach as they kind of got it and as the work with Circle has been done. There are, however, two of our acutes to whom we would normally send patients who have actively said we do not want to sign a subcontract with Circle. Now that said, although our patients would naturally flow to them, they tend to be the two of the hospitals to whom fewest of our patients would go, and they're being managed through non-contract activity. So, there we go. We've got a few more minutes if anybody wants to ask any other questions or make any comments.
I think we might have a few more questions
coming,
Diane.
Oh, yeah, here you go. You love technology.
Yeah.
Okay, so how detailed is the final service spec in the contract? So the service spec in the contract is almost exactly, I think, bar one sentence, despite the service spec that went into the IPT document. And what we did in that was describe the musculoskeletal system in terms of that third sector of the qualitative outcomes that we expected. It describes the musculoskeletal system in 4 stages or 4 parts, very much based around the feel for patients, the way that patient empowerment, patient involvement in decision making, and the way people can care for themselves should be a big part of this. Something about what the offer is to GPs and how GPs are involved. Then the third part is the community-based part, which is the meat of the integrated system. And the fourth part then is what we expect acute trust to deliver, and the push-pull with the community and general practice of patients in and out of the acute sector in the minimal and safest amount of time. I've got a few more questions to come through, which is around double running costs with our acute providers. No, we have the programme budget. We were very, very explicit that the programme budget we've had at the hospital includes all the money we would have for musculoskeletal. So when those hospitals are non-contracted come in, the money for that non-contracted activity comes out of Circle's budget and not out of ours. Next one, COBIC hinted at in the proposed tariff changes. That's a really good question. I couldn't possibly comment. I know that items-based commissioning as a way of doing business is something that NHS England has been promoting, and Monitor have been very interested in items-based commissioning in terms of sort of the markets and how markets need to respond. So it wouldn't surprise me that items-based commissioning has been taken on board in terms of the way the future tariffs and the future way the markets need to work is being done. How do you practically get the acute to work with you to calculate your programme budget? I was not able to identify service level costs. Yeah, that's a really good point. We had a very rough and ready budget, especially for our community sector, and to some extent we didn't have a problem with the acute per se because we used the SLAM data we get month on month to basically work out what our spend was. In terms of the community contracts, we probably had more problems there because service level reporting was much more rudimentary, and at the end we tried debating directly with their podiatry manager as to what was musculoskeletal and what wasn't, and have put in a level of assumption which we're testing in year one through like an open book approach. Next question then is around knock-on effects to trauma levels. No, there hasn't been any direct impact on specialist trauma services by the two acutes. One of the acutes that isn't taking part is the major trauma centre, as in it's the one where you get a helicopter to with cardiothoracics and everything else. So this is a small part of their overall budget, and it will have very little impact on them. The other, again, we're not a big part of their budget, and they're confident they can retain, and they're quite happy able to retain their specialist trauma services without being in contract with Circle. Our local district general, the one who has been an impact, is actually part of a whole systems health service review at the minute, which is looking at whether trauma services will actually be provided there in the long term anyway. And final question so far, higher payments made to the outcomes. They're made, we have about 15 indicators, and they're made on a quarterly basis per indicator. And there are some of them are black and white, yes and no, you've done it or you haven't. Some of them are achievements of thresholds, and again, it's pretty binary as to how we pay for each indicator at each quarter. We're
just coming up to 2 o'clock. One more, yeah.
Okay, so final question then on marginal rates for inpatient activity. It's just bearing in mind that PBR tariff is subject to local and national rules. So the tariff price you see on a spreadsheet is not necessarily the tariff price that we pay and a trust might receive. There are some rules which especially apply to the marginal rate for emergency inpatient activity. If it's above the 2008-9 threshold, the trust will only be paid at 30% of the tariff, as opposed to the full tariff rate. So less relevant to electives, but definitely relevant if you're looking at urgent or emergency care systems.
Diane, I mean, clearly there are a lot of questions that people have, and we talked just before the session about setting up a couple of afternoons where you would be able to actually take calls from people who were interested. So for those of you that would like to have a short telephone conversation with Diane, so relating to questions that you have from your specific area, she's actually identified 2 afternoons, and that will be Wednesday the 6th of August and Thursday the 7th of August. So if you'd like to contact me, and I will actually book in a slot for you. We're thinking probably about half-hour slots somewhere between 1:30 and 5. So if you'd like to have a half an hour of Diane's time to talk about your to talk about your specific questions, then please just drop me an email and I will set that up for you. But I think all that remains really for me to say is thank you very much indeed, Diane. I think it's been a really interesting session, and we will follow up with the presentation out to you, and please do contact us if there's any additional information you'd like to receive. So thank you very much.
Thanks very much, Sally and Joe.
Bye-bye. Bye.